All right, so activity 1 of your heart anatomy lab says that you're a famous surgeon and you cut the sternum in half lengthwise and pull it apart to expose the mediastinum. What should you see covering the heart that's not displayed on the models? And so if you open up the torso model from the lab, what's should be covering the heart that is not is just the pericardium. So you're not seeing the fibrous pericardium, you're not seeing the parietal pericardium, and you're not seeing the visceral pericardium. Well, you are a little bit. The yellow here is part of the visceral pericardium, but it's really more to display it as the epicardium or the heart wall. And because remember, those two things are the same thing depending on what you're referring to. So it's the visceral pericardium if you're referring to the serous membrane or the pericardium around the heart. It's called the epicardium if you're referring to the heart wall itself. The next part of the lab says to push aside the lobes of the lungs that are partially obscure or that partially obscure your view of the heart, and notice that 2/3 of the mass of the heart lies to the left of the mid-sternal line. So if you take this out, pull off the left lung, you'll notice this is the midline here where the trachea is. Most of the heart sits on the left side, so it's not perfectly in the middle. It's a little bit left leaning, which is why, and we'll learn this a little bit later, which is why there are 3 lobes of the heart, but or 3 lobes of the lungs on the right side, but only 2 lobes on the left side, because there's less tissue because it had to make room for the heart that sits more on the left side, but we'll get to that later. Find the apex, the narrow pointed end at the heart that points toward the left hip. The beating of the heart is best felt or heard where this area is closest to the chest wall, because remember, the apex actually faces a little bit anterior. So again, it's not on the midline, it's a little bit to the left, it's also oblique, and the apex is a little bit anterior. And so we call this the point of maximal impulse. So you can go to a skeleton and find this area at the level of the 5th intercostal space, so between ribs 5 and 6 on the mid-clavicular line. So if we go to the skeleton here, this is rib number 1, rib number 2, 3, 4, 5, and 6. So in this space here at the mid-clavicular line, so right here is the mid-clavicle, and again 1, 2, 3, 4, 5, and 6. So right here, 2, 3, 4, yeah. So right here, I had to count just to make sure. But right here on that mid-clavicular line, that's where you should be able to feel the point of maximal impulse. It's going to be easier for some people than others. People with breasts, obviously, it's going to be a little bit harder. You have to kind of go underneath to feel between that space, but you should be able to feel the PMI there. That's part of activity 1, and then it wants you to identify the following great vessels. I'm going to show you on the larger heart model because that's most likely what we're going to use for the exam. And I guess I can show you on the smaller heart model too, just so you have more examples. So I'll go on the big heart model first, the superior inferior vena cava. So number 16 here is the superior vena cava. Down here is the inferior vena cava. So don't get confused. These 2 little branches here, if it can focus, 17 and 18, those are 2 separate vessels. Those are brachiocephalic veins that we'll learn about later. We only have 1 singular superior vena cava, that is number 16. And again, inferior down here. Then next is the pulmonary trunk and arteries. So this is the pulmonary trunk. Blood has to pass through that pulmonary semilunar valve before getting there. So there's the pulmonary trunk. And then this is the left pulmonary artery going out to the left lung. And if we turn this around here, this guy right here is going to be the right pulmonary artery going to the right lung. Then the pulmonary veins, we actually have 2 on either side. So here is the left pulmonary veins. And if you want to be even more specific, you can say the left superior pulmonary vein and then the left inferior pulmonary vein. And on the other side, we have pulmonary veins here and on the right side. And again, you can say the right superior pulmonary vein and the right inferior pulmonary vein. On a practical, I'll give you points for just saying pulmonary vein on the right or left. but you may get a little bit extra, maybe a 1/4 of a point, if you remember to put superior or inferior. And then the aorta. So the aorta is this large vessel here. Blood will pass through the aortic semilunar valve, which is all the way inside there at number 45, before it gets to the aorta. So there's that. We'll learn about the parts of the aorta and the branches of the aorta later, but for now, just the aorta. And then there's a little activity here. So hopefully you've done it already. It tells you to label those major vessels on these diagrams. So the vessels that take blood from the heart to the lungs are the pulmonary arteries, because remember, arteries mean vessels that go away from the heart. So going away from the heart are the pulmonary arteries to the lungs, and veins bring blood back to the heart. So the vessels that bring blood from the lungs back to the heart are the pulmonary veins. For the systemic circuit, the vessel that takes blood from the heart to the body, again away from the heart, is the aorta, and the aorta is an artery. And then the vessels that take blood from the body back to the heart are the superior and inferior vena cava, and those are also veins. Okay. And that's it for activity 1. Just kidding, the rest of activity 1 is going to be, I'm going to show you those same vessels on this model. So the pulmonary trunk is here, and then it does branch off into the right and left pulmonary arteries. So I'm going to place that here. We're looking on the posterior side. So now right is going to be right and left is going to be left. This is the right pulmonary artery. This guy right here is the left pulmonary artery. And then, oh, I guess we can do that on the posterior side too. These are the pulmonary veins. So again, we're looking at the posterior side. So this is right and this is left over here. So this is going to be these are the right pulmonary veins and the left pulmonary veins. Again, superior and inferior, superior and inferior. And then the inferior and superior vena cava. So superior vena cava right here, number 144. Inferior vena cava down below here. And then the aorta is actually, you have to put the heart in there. And then this guy right here is the aorta, 151. That's all of activity 1. Okay, so activity 2 is about all the internal anatomy of the heart. So first of all, we're going to go to the right atrium. This right here is the right atrium. And then it says to find the entry points for blood from the superior and inferior vena cava. So superior vena cava takes blood into the heart from the top part of the body. The inferior vena cava down here takes blood back to the heart from the bottom part of the body. And then the coronary sinus opening is also going to receive blood from coronary circulation, and that's number 58. You see that little red spot right there? I'll get closer so maybe it'll focus. But that red spot, number 58, that's blood, which is coming into the heart from the back of the heart at the coronary sinus, which I'll show you later in this video. Then you find the slight depression in the interatrial septum called the fossa ovalis. So first of all, the interatrial septum is the wall between the two atria, so it's going to be this wall here. So on a practical, I may just put a sticker maybe right here on A and B, and then I will say, referring to A and B, what is the wall that separates these two chambers? And then you would say is the interatrial septum. And then the fossa ovalis, which is a remnant or leftover of the fetal foramen ovale. Remember, the fetal foramen ovale is the hole in between these two atria that was present during fetal development because the lungs weren't inflated yet, and there was not a need for a systemic and pulmonary circulation. So there used to be a hole while we were fetuses. And so just prior to birth, that hole should close up and create a remnant, which is an indentation here at number 55, called the fossa ovalis. Then the tricuspid valve is right here at number 35. Remember, the tricuspid valve is going to be just the flat portion of this structure right here. Okay, while the strings here are going to be the chordae tendineae. So the flat white part is the actual tricuspid valve, and then the cords or strings here are the chordae tendineae. Those are going to be attached to papillary muscles, which are the red here. Those are all papillary muscles. So those will contract to pull on the strings and then close up the valve. And then the lab says, for a valve to hold the closed position, the flaps, the tendon, and the muscle walls, which are the papillary muscles, will be in good working order and disease-free. Leaky valve sounds called heart murmurs, or leaky valve sounds cause, leaky valves cause sounds called heart murmurs. And little leaks are okay, but cardiac insufficiency results if big leaks allow blood back into the atria every time the ventricles contract. So again, the papillary muscles and the chordae tendineae are going to pull. Well, the papillary muscles are going to contract, pull on the cords to close the valve. If the valve doesn't close properly, like maybe in the case with endocarditis, then you may have backflow of blood back into the right atrium, which ultimately is going to cause the heart to work harder because it's having to repump blood because it keeps backflowing. So that is the right atrium and the right ventricle. The, what's next? Actually, right ventricle. So we talked a little bit about the right ventricle with the tricuspid valve, but the right ventricle on your lab says to locate the right ventricle and the interventricular septum. So this is the right ventricle here. Interventricular septum is here, the wall that's separating our two ventricles. And then it mentions to find the pulmonary semilunar valve that will open when the right ventricle contracts and allows blood to the lungs. So this right ventricle will contract and build up pressure. This semilunar valve will eventually open. It's the pulmonary semilunar valve will eventually open and allow blood into the pulmonary trunk and into both pulmonary arteries out to the lungs. After that, we have the we have the pulmonary trunk. The blood is going to go from the right ventricle past the pulmonary semilunar valve, up the pulmonary trunk, out the pulmonary arteries, and then to the lungs. And then that blood will return through the pulmonary veins. And remember, this is the left superior pulmonary vein and then the left inferior pulmonary vein. You'll have the same thing on the right side from the right lung, right superior pulmonary vein, right inferior pulmonary vein. And then after blood goes into the left atrium, it's going to go past the bicuspid valve. Remember, you try on the right side before you bi on the left side. That's kind of how you can remember which one is which. You try before you bi. Another way you can remember is that it's called tricuspid because there's 3 cusps of the valve. That's why you have 1, 2, 3 papillary muscle connections versus the bicuspid, which has 2, one and 2 behind it. But again, you try before you bi. So the flat part is the bicuspid valve. These are the chordae tendineae, and the red where they attach are going to be the papillary muscles. The bicuspid valve, though, is also sometimes referred to as the mitral valve. There's a little bit about mitral valve prolapse in your lab. So 2 to 5% of the population are affected by genetic birth of chordae tendineae, allowing valve flaps to bend backwards into the atria. So these would bend backwards into the atria, causing a prolapse during ventricular contraction. And infections from IV drug use can also increase your risks of mitral valve prolapse. If severe damage surgical correction done by inserting an artificial or pig valve. I don't know why it says if. Okay, I get it. If severe damage, surgical correction can be done by inserting an artificial or pig heart valve. For the left ventricle, do remember that the left ventricle is going to be thicker and more muscular than the right ventricle, just because the right ventricle pumps out to the lungs, which are right next to the heart, not a very long distance. But the left ventricle pumps all the way to the top where the brain is, and then all the way down to your toes, so a much larger distance, so it needs to be much thicker in order to be able to pump that blood a much farther distance. And then from the left ventricle, blood is going to go through the aortic semilunar valve. So if we go inside here, it is this valve right here, number 45. That is the aortic semilunar valve. And once there's enough pressure in this ventricle, that aortic semilunar valve will open and allow blood up and out the aorta. And then your lab mentions that a narrowing of this valve or proximal aorta by calcium other deposits is called aortic stenosis. So remember, stenosis is going to be the narrowing of that vessel. And this is, think about what happens if the left ventricle cannot pump enough blood because of this condition. So if the aorta is too narrow, not the aorta, but the aortic semilunar valve. If that valve becomes too narrow, the opening becomes too narrow, then you're not going to be able to pump enough blood out. And so it's going to cause more strain on the heart to get enough blood out to service the body. So then your left ventricle enlarges as it stretches out by working longer and harder. Your blood pressure goes up as a result, and the heart will weaken over time, and you may need a valve replacement for that aortic semilunar valve. And that's activity 2. Okay, so activity 3 is all about the blood supply to the heart. Coronary arteries right and left, you're going to find their origin within the first half inch of where the aorta leaves the heart. And then I don't have the other model here to show you, but I'll show you where they come off of. So here is the aorta here. Here is where the right coronary artery comes off the aorta. Now the left coronary artery, you can only see a small piece of it right here, but it would come off of back here off the aorta. It's just that the pulmonary trunk is in the way, but off the aorta, the left coronary artery comes off, but you only see a small piece of it. And remember, the heart needs coronary circulation, so we need to feed the heart on the outside, because one, the heart, or the blood inside the heart, again, it's not to feed the heart itself, that's for delivery to the body. And your heart wall is much too thick for the blood inside the heart to diffuse all the way through and get all those cells with enough oxygen and nutrients. So we use coronary circulation to feed the heart itself. So those are your right and left coronary arteries. You'll notice that, again, we only see a little piece of the left coronary artery here, and then it automatically splits. It's going to split into the circumflex artery, which wraps all the way around the back of the heart. And then you have now there are a couple different names for this vessel. So again, circumflex goes in this direction. Another branch of the left coronary artery is this artery here, which you can call it the anterior interventricular artery, because that means that it's on the anterior part, and interventricular, inter means between, so it is a vessel in between the two ventricles. In clinical settings, it may be referred to as the LAD, which stands for the left anterior descending artery. So on an exam, you have to make sure that you do not give me the abbreviation, or else you will not receive full credit. It is the left anterior descending artery, if you want to call it that, or you can call it the anterior interventricular artery. And then the right coronary artery has a branch called the marginal artery. So here's 31, comes down here. This is the right coronary artery. And then 63 right here, that is the marginal artery. Your textbook may refer to it as the right marginal artery, but I'm okay if you just call it the marginal artery. Either one is fine with me. There are a couple of anastomoses on this heart, although only one is accurately displayed. But anastomosis is when you have a reconnecting of vessels that creates an alternate route for blood. So one example is that this right coronary artery here and this circumflex here, they both round around the back of the heart. And actually, I'm going to have to remove this so I can show you. So the right coronary artery is coming this way, the circumflex is coming this way, and they meet up at the back of the heart. That creates an alternate circulation, because let's say that there was a blockage, and I'm going to put this heart back on its stand here. Let's say that there was a blockage right around here, okay, of the circumflex. Now that blood can't get that way, but because there's that anastomosis, or that reconnecting at the back, the blood in this right coronary artery could come all the way back and feed that part where the blockage is. So it could come back and reroute. And so it creates an alternate route, because the heart needs oxygen, it needs blood all the time. So if we have these alternate routes, they can make sure that the heart is getting enough oxygen until you can resolve that issue. Another anastomosis, which again is not shown accurately on this model, is that anterior interventricular artery, or the LAD, and the posterior interventricular artery. So on the back, number 61, that is the posterior interventricular artery. If you look at the apex, you can't see where the connection is, but they do meet here. So the anterior and the posterior interventricular artery on here, and then on the back side, meet up right here at the bottom. Your textbook shows that accurately. This model, for whatever reason, just does not. But just know anterior and posterior interventricular artery have an anastomosis, and then the right coronary and the left, or not the right coronary and the circumflex, which is on the left side, have another anastomosis on the back side of the heart. And then all of these blue vessels here, those are all cardiac veins. So the red means oxygenated, blue means deoxygenated. So these coronary arteries are all oxygenated. They deliver oxygen and nutrients to the heart itself. And then the blue vessels are going to return that blood to the heart, to the inside of the heart. So all of the deoxygenated blood, after we've delivered the oxygen to the heart, the deoxygenated blood returns through these blue cardiac veins and dumps right into this large vein called the coronary sinus. So that's where all the deoxygenated blood from the outside, from coronary circulation, goes to, number 27. And then that's where I showed you earlier, that coronary sinus, that large vessel there, number 27, it's going to empty right there at number 58 at the coronary sinus opening. Okay. And then another part of your lab was to do a CABG. Now this one already has all 3 CABGs done already, so I'm just going to kind of run through what a CABG is. So a CABG is a coronary artery bypass graft. It's a way that we can take vessel tissue and we can restore blood flow where there's a blockage. So for example, one of the activities in your lab, number 1 here, tells you that there's a blockage at the proximal LAD. So proximal LAD means that it's going to be the LAD, but proximal means right where it branches. So right where it begins, that's where our blockage is. So we have a blockage in the proximal LAD here. And so for a CABG, we're going to take a little bit of the blood from the aorta, and it's safe to take it from the aorta. It's a big vessel, lots of blood in there. It's a larger vessel than any one of the other ones. And so we can take a little bit of blood without compromising the pressure too much. So we take blood from the aorta, and remember the blockage is here. So we go past the blockage so that this blood in this vessel here can go from the aorta past the blockage and restore blood flow downward. Because if there was a blockage here, now this part of the heart is all starving for oxygen. So by doing the bypass, we bypass the blockage, and now we can restore blood flow. The other one is to do it on the right coronary artery. So again, we take a little bit of blood from the aorta, go past where the blockage is, somewhere in here, and now we can restore blood flow going forward. Now, I don't like where this one is placed. This one has the bypass placed on one of the branches of the aorta. I don't like that because this is a smaller vessel, and you don't really want to take blood from a smaller vessel like that. On the exam, I would have it either here on the aorta or down here on the aorta. But either way, and I can't remove these. This is the new model, so if I try to pull, they're not coming off. I'll have to use some pliers or something. But again, it would have came from here or here, from the aorta. But if the blockage is in the circumflex, let's say there's a blockage right here at number 49 where the circumflex is. Now, if there's a blockage here, none of the back part of here is receiving blood unless we do the alternate route here. But either way, it's a problem if there's a blockage here and blood can't get past that blockage. So we could take some blood from the aorta. I know it's here, but it would be here. And put it past that blockage there, and now we restore blood flow. So that's a CABG. Okay. And that is all for activity 3. So the last activity is slice man. The first thing I want you to find is the right and left lungs. You can find that on a couple of the slices. Slice number 8 here. I think it's, yes, number 8. Here are 2 lungs. And again, this is the front side of the body. This is the back side of the body. So this is the left lung. Here's the right lung. It's also going to be on slice 9. My slice man's a little wobbly. So again, left lung, right lung. And then you can still see a little bit on slice 10, the left lung and the right lung. Next is the sternum. So if you look on these models, here's the sternum here, right in front of the heart. Again, the sternum here. And then the next thing is the mediastinum. So the mediastinum is a subcavity of the thoracic cavity. And the mediastinum is going to be between each lung and then between the sternum and the vertebrae. So this small space here where you have the heart, the esophagus, and then also the trachea. Now these are the great vessels of the heart here, aorta here, superior vena cava here. There's the trachea, esophagus. Even this is still mediastinum. So if I ask you for the cavity that this organ sits in, you want to be as specific as you can and say the mediastinum. And then again, the esophagus is here. You can see it also here and also here. So those are all going to be the esophagus. And again, right here. And then next is the parietal pericardium and the pericardial space. So right here, now it's really hard to tell because these are very thin lines, but right here inside here, that would be the the parietal pericardium on the outside lining that mediastinum, and then actually touching the heart would be the visceral pericardium. So visceral pericardium, parietal pericardium against that wall, and then the space in between right here, that would be the pericardial cavity. Okay, and then we have the atria and the ventricles, and then we'll be done. So here is the right atrium, left atrium, and again, both of these spots are the right atrium. So right atrium, left atrium, and it looks like this because remember, the heart isn't just right in the middle, it's a little bit to the left, and the apex is a little bit forward. So the base of the heart is actually laying a little bit more back. So that's why it lays kind of like this. But again, left atrium, both these little sections here are right atrium. So this wall right here, and I'll get a little bit closer. This wall right here is the interatrial septum. Here we have the left ventricle, here's the right ventricle, and then here's the interventricular septum. And I believe, I guess we can go here too. This is still heart, but this is going to be right ventricle, little space here, left ventricle. I wouldn't tag that there, but I may ask you what portion of the heart that is, and you would tell me it's the apex. And that's it for size, span, and activity 4.